So, welcome to Working with Homelessness in Hospitals, Module 3 of this brief training programme. And this module will focus on giving you some top tips as to how you might help people experiencing homelessness when you meet them in hospital. So my name's Sam Dorney-Smith and I'm a nursing fellow for the Pathway charity. And Pathway lobbies around the provision of better healthcare for people experiencing homelessness and other people who might have difficulty accessing care. And I'm joined in this module 3 by two excellent colleagues, Jeff Parker, who's an expert by experience, and Mo Elmi, who's the expert by experience project lead at Pathway. So I'm sure you'll recognise this common situation. A bed manager or a ward manager comes to you and says, we're on red alert or black alert, whatever it is in your hospital, we need to get this patient out ASAP. And it's really important to work with that because we all know what pressure there is on beds. But sometimes this leads to some really difficult situations. So this is a real quote from a bed manager in a UK hospital. He came in homeless, why can't he go out homeless? And it's a really good question because there may be some situations when somebody does have to get discharged to the street, but we want it to be a very rare circumstance because there's a real moral imperative to help. But also we know that homeless people are often repeat attenders due to their complex health needs and their lack of access to primary care. And we talked about that in module 1. And then what happens when health needs are not met is that their health deteriorates and they then get admitted for long periods and they become delayed discharges. So it's really important to note that managing the health of people experiencing homelessness will both save lives and improve hospital efficiency. And that's an important pushback for your bed manager or your ward manager at that time. Now, before I go on to talk about some of the things that you can do, I first wanted to give you some context. So I'm going to hand over to expert by experience, Jeff Parker. And I just want him to give you a feel about how it might feel when people experiencing homelessness come to hospital. So Jeff, could you tell us how you think people experiencing homelessness feel when they come up to A&E?
I still feel the same way now. Every time I go into hospital, I remember the days when it's happened, when I was homeless, when I've been in hostels and such, and gone in, and I still have the same feelings. My hands go clammy, my heart rate increases. I'm scared. I'm physically frightened because I've been assaulted before in there. I'm mentally terrified. My brain's screaming at me, don't go in, don't go in. To the point that I've even thought in the past, well, I just won't go in, I'll just die. I don't care. It's better than going in and being treated like this. I've been sprayed with air freshener. I've been told to go and stand at the back and wait till the normal people have been seen. And when the staff are saying things like that, it's not just saying it to me. There's all the people around me, so they then move away, so they then treat you differently. People start doing this with their nose, and there's no smell. It happened to me once. I was in a hostel. I'd had a shower 20 minutes before I got to the hospital, and a nurse came out and sprayed me with air freshener. I'd just had a shower. I didn't smell, but she assumed, because I was telling them I was homeless and needed help, she just assumed I smelt. That should never happen. I hope it never happens to me again. But every time I go now, I worry that that sort of thing will happen. And I'm no longer homeless. I dread to think what it's like for those out there now.
So thank you very much, Jeff, for sharing that awful experience with us. So I'm now going to go on to talk about how you can help, but we're going to go back to Jeff in a minute. So there's a number of ways in which you can help, and I'm going to review these at the end. But the first one is to give a warm welcome and make reasonable adjustments. And I'll explain what that means in a minute. But with regard to the warm welcome, we know, don't we, that a kind, non-judgmental approach goes a really long way. And we need to remember all the challenges that many people experiencing homelessness face when they're coming to hospital. And Jeff has just articulated some of the awful fear and anxiety that people feel about coming to A&E when you know, they might be worried about the health conditions that they're going to find out about. But there's all the existing things. They're worried about the fact of being stigmatized. There are the day-to-day survival challenges that are going on in their heads. There's mental health, addiction, cognitive issues, lots of barriers that we talked about in module 1. People have already had difficulty accessing primary care for a variety of reasons. They may have been used to being knocked back. And there's all the issues that may have been barriers to actually getting to the hospital, having no credit on the phone or ability to travel, and practical challenges like who will look after my dog, for example. If you're a single homeless person, you have a dog, just finding someone to look after the dog may have been a significant challenge. So just remember, when someone arrives there, all of the things that might have happened prior to them getting to you. So with that in mind, I'm going to ask Jeff to tell us a little bit more about the kind of attitudes that Jeff feels that staff sometimes display when people come to a hospital, but also what difference a nice, kind attitude can make to somebody when they arrive at the hospital. Jeff.
Okay, let's go with the worst ones then. I remember being in a queue in a hospital in the city where I live many years ago now, and I'm standing there waiting to see, and there's an old lady in front of me, and she got to the window, and I heard the girl behind the desk say, "Hello, good morning, what can I do for you?" And she had a little chat with her, and she sent her on her way to where she needed to go. And then I went to the window, and she said, "What do you want?" Total opposite. And I was like, have you got no humanity? Literally. If that's your attitude, you can get out. So, well, can you just be nice and let me tell you what's going on? And at that point, she called security, and I was removed. I was taken out of the hospital. Not a nice attitude, not a good start. I hadn't done anything wrong. All I wanted was to get some help. But on the other side of it, I've gone in before, and it's the total opposite. You'll get people who don't judge, are quite really nice. What can I do for you? Can I help? Do you need anything else other than taking you to where you're going to go? And they'll take me. I've been taken to areas and shown where everything is and really treated with respect. But you don't always get that. I had an incident that was not nice at all. I'd taken an overdose. I decided life was better dead. So I'd taken an overdose, and I overheard a nurse say, "People like him should be just left to die." And I lay there thinking, am I going to die? Are you just going to let me? Please don't let me die. But a nurse should never say that about anybody. Doesn't matter who they are. It should never, ever be allowed to happen. But that is the attitude, unfortunately. There is some really good staff in hospitals, but there is some really, really bad ones who just don't care about us at all.
So thank you, Jeff, again, for sharing that really poignant experience with us. And, to summarise, it's not difficult, is it? What we're hoping that you get from this is how much difference, just a really nice, warm approach will make to somebody when they come to hospital. So then moving on, the next thing that's really important is identifying homelessness early, so you've got plenty of time to help someone. So ideally, your accident and emergency receptionists should be recording housing status on admission, although I do understand that's a systems thing and you may need to work through the processes to get there. But either way, initial nursing assessments should also ask about housing status and any discharge challenges, and that should happen right at the beginning of an admission. It's really important to remember that patients are often embarrassed about their homelessness and may be reluctant to talk about it. So this needs to be allowed for. You need to ask really kind, open, gentle questions that really suggest that you want to know the answer. For example, do you have any concerns about where you're going to go on discharge, or where do you live at the moment? Are you okay to go there on discharge? Just so that you're really inviting a response. Thirdly, as has been discussed in module 2, and if you haven't done module 2, I suggest you go into it now, is that you need to do the duty to refer with consent, because public bodies in England have a statutory duty to refer individuals who are homeless or who are at risk of homelessness to a local authority for housing support, assuming they consent to this. And as is discussed in module 2, this duty applies to hospital wards, outpatients and A&E departments now, and it applies regardless of whether you're a clinician or a non-clinical support worker. So number 4, very simple thing, is to signpost people into community services. And I've put up a link here to the Homeless UK site. And you'll see on the right hand side there's a green button which says Find Homeless Services in England. And if you click on that and put on your postcode, you'll find that it comes up with a list of all sorts of relevant services, homeless services, mental health and addiction services, and it's updated every 6 months. So this is a really excellent resource, and you can print out the information that you get there. But you might also want to think about appointing a link worker within your services to find out and build relationships with local services so that you know a little bit more about them and what they offer. Just as an aside here, we mentioned earlier that it may be in some cases that unfortunately someone does have to be discharged to the street, although this should be a very rare occasion. But you can help people in this situation by referring them to their local outreach team. And you don't need to know the details of the local outreach team. You can refer via StreetLink. You can download the StreetLink app onto your phone, or you can find them on the web on any computer. And what it enables you to do is refer somebody who's rough sleeping to the local outreach team. It will automatically get fired off there. But just to know that the information that's requested is a description of the person and their belongings, their sleep site location, so that the outreach know where to go, the times of day they're there, risks and contact details. So this is not necessarily information that you'd normally be asking. So bear that in mind to try and get that information before somebody goes if they're returning to rough sleeping. Another thing to do is improve your discharge information. So here is an A5 booklet that's been produced by UCLH. It's waterproof, it can go in your pocket, and it provides information on all of these things on street outreach teams, on homeless day centres, on night shelters, on soup runs. But it also provides really key information on things like health and housing rights, welfare advice, where to access mental health, addictions and sexual health services. And there's shorter versions translated into other languages and in large print. And there's other leaflets around specific local borough areas. Now that may be a bit ambitious, but either way, maybe if you appoint a link worker, they can provide just some downloadable leaflets on the internet, on the intranet, that you're going to be able to access in the middle of the night, which really might make a difference to somebody. Number 6, now we talked in module 1 about people's difficulty getting access to primary care, and this is a really important thing that you can do to intervene. So Groundswell have produced something called the My Rights to Access healthcare card, and you can see a picture of it there. It's a plastic credit card style card, and you'll see it says on there, I do not need a fixed address, I do not need identification, my immigration status does not matter. Now, 70,000 of these cards are out in distribution at the moment, but if you contact Groundswell, you can get a supply. And we do know that people who have repeatedly turned away from primary care, if they take this card to a GP, actually the attitude that they get is somewhat different, and it may be helped by the fact that it suggests to the person that they should inform Health Watch if they get turned away. So it really might be worth having a stack of these cards available to give to somebody if they've been turned away from GP registration, or maybe just help them, maybe help book them an appointment, maybe tackle that GP practice when they're in hospital with you. Just as a quick note to say, there is no requirement for a homeless person to register at a specialist homeless practice, even if there is one available. It might be that you feel that actually somebody's got multiple complex needs and actually it would benefit them to have long appointments, and you might suggest that. But if somebody wants to register at mainstream practice and that's where they're homeless, then they've absolutely got the right to do that. So please try and remember that. But also, if there are challenges with GP registration locally, it may well be worth getting the voluntary sector involved. So, for example, Groundswell have a homeless health peer advocacy service that's currently operating in most parts of London, Birmingham, Manchester and Newcastle. And this is where homeless health peer advocates, who are people who've had a history of homelessness, will work alongside currently homeless people to get registered with GPs and access primary care. It's really worth finding out whether similar services are available locally that maybe people in your discharge team can work alongside and refer to. Number 7, this is probably the most important part of this presentation. If your patient has to be discharged to the street, then safeguarding issues and mental capacity must be considered. So I'm sure you'll all know from the changes to the Care Act in 2014 that self-neglect is now a legal duty under safeguarding. So if you think somebody is self-neglecting, then they need to be referred to safeguarding. But I can tell you that self-neglect is often missed as a safeguarding issue. And in this review, which you can click through to, of safeguarding adult reviews that have taken place after death on people experiencing homelessness, failure to refer people to safeguarding for self-neglect has been a key area that has been identified as something that hasn't happened, as well as inadequate mental capacity assessments. And I'll talk about that in a minute. So the key message here is, if you think somebody is self-neglecting, then refer them to safeguarding, and also discuss it with your manager. Because remember from module 1, we've had a huge rise in homelessness deaths, and that's what this is about. It's about saving lives. But also it's really important to put across to your managers that this could also be seen as organisational neglect, and essentially your organisation could be getting sued. So it's really important to think about self-neglect as a safeguarding issue. On to mental capacity. A mental capacity assessment should always be considered if someone's being discharged to the street, and definitely always be undertaken for someone who's self-discharging or refusing treatment. Key points around the mental capacity assessment that I'm sure that you will recognise: it can be undertaken by any member of the clinical team. An assessment is needed every time that someone presents, because mental capacity is situation specific and it often fluctuates. So it's really important. It's not accurate to say he's got capacity. All assessments should specify what he's got capacity for and when. So whatever the nature of the discharge, a mental capacity assessment might be required. So obviously it's required if someone's self-discharging, but if someone has evidence of underlying mental illness or cognitive deficits, or even if they've just got underlying serious health problems, they may not need to be in hospital now. That may be the decision of the consultant, but we need to assess whether they are safe to return to the streets. And we need to be really clear about what that assessment is about when it's being undertaken. It's about whether the patient is being safe to be discharged to the streets, or refusal of treatment, or whatever it is specifically focused on. And just a reminder that really what that assessment needs to include is all of these things. It shouldn't say patient has capacity. It should say this patient's capacity has been assessed around their ability to maintain their own safety on the street, and there should be documentation of this person's ability to understand this information, retain it, use it and weigh it up and communicate it. Which brings us to the most common challenge. It is very, very common for people experiencing homelessness that when someone's trying to do a mental capacity assessment on them, for a variety of reasons, they will not engage. They're suspicious. They don't understand why someone's trying to do it. Maybe there are behavioural issues anyway, but often they really think they're being tested, and they think that perhaps someone's suggesting that they're stupid or whatever. And obviously mental health problems and language difficulties can play a part in this. So you really need to stop and think. These situations are complex. We know that these clients have complex health needs, and we know that they die early. So you need to think, have you done everything possible to communicate effectively? And if you can't do a mental capacity assessment, this isn't the point for you to, yourself assume that someone has capacity. You need to discuss the situation with a senior clinician, and it may need to go on to an MDT discussion. So it's a really important message to take away. Just a note about patients with no recourse to public funds. They always need to be treated the same as people with recourse. They can access the same primary care, they can access the same support services, but with regard to mental capacity and safeguarding, obviously they need to be treated the same. And just to say, if you've got any questions about charging or other things related to no recourse to public funds, the no recourse to public funds network advice pages are a really good place to go, and the link is there. That probably all sounds really complicated. So just to say, there is a really excellent checklist available on the Healthy London Partnership website, which you could use in your hospital, in your A&E, or maybe you could adapt locally, but it goes through all of the things that you might need to think about if someone's being discharged to the street. Finally, we're nearly at the end. So number 8 is get feedback on your care. So an example here is of a feedback form that's been specifically designed by our Expert by Experience program to be better able to get feedback from people experiencing homelessness. But you might want to think about doing focus groups or interviews, for example, at a local day centre, going out to find out what people really think of your hospital service, or just ask. So if you know someone's homeless, just ask about their whole experience. You know, how was it at the front door? How was the receptionist? You know, how have they been made to feel during their time here? And you may find that people really, really appreciate it, but really want to engage. And some of those people may want to go on to become experts by experience. And if they do, then we'd like to hear from them. So I'm just going to hand over to Mo Elmi, who's just going to talk a little bit about Pathways Experts by Experience program.
Hi, I'm Mo Elmi. The Pathways Expert by Experience program is quite a unique thing. We take people with lived experience, train them to try feedback into the system as a whole, to try speak to truth to power in a nutshell. It could be in multiple different ways. It could be an academic starting the beginning of a study, and they'll help them in a form we call co-production, where they'll mold the study over a number of months, sometimes even in some cases years. It could be helping out local CCGs in terms of molding their services and working out how the delivery in the local areas would work out. It could work for people that are looking to come into the health service and deliver a particular project or a pilot. And the expert by experience could show them how people from their particular backgrounds and their experiences can help shape and mold it. If you are a clinician and you bumped into a person with lived experience, we could connect them to sort of wider training opportunities. And the expert by experience is the home of that type of offer. So I urge anybody that wants to join this program or thinks of someone that would like to join it to contact Pathways at ebe@pathways.org.uk.
Thank you very much, Mo, and I'm sure you'll have seen from this presentation how vital the contribution of experts by experience is. So, to summarise how you can help. 1, give a warm welcome, make reasonable adjustments to help people access healthcare. Identify homelessness quickly in your hospital, and then do the duty to refer for homeless individuals, assuming their consent is given. Signpost people to support services, and to help with that, improve your discharge information. Help get patients registered with primary care, and really importantly, ensure that mental capacity and safeguarding risks are assessed carefully as someone's going to the street. And then finally, get feedback on your care, you know, and get people involved. Just as a last thing, just a reminder that if you do have a lot of people with experience of homelessness coming to your hospital, that it may be appropriate for you to have a pathway team. You know, we believe that multidisciplinary, multi-agency care coordination will benefit people experiencing homelessness. The approach essentially centres around having a consultant GP within a multidisciplinary team to work in a ward round with community partners to deliver long-term health gain for people experiencing homelessness, as well as appropriate housing. And it's always focused on involving people with lived experience. And the pathway model, we now have 11 teams around the country, but we've got lots more coming online, and we're looking for more. So please do get in touch. The pathway approach has been cited as best practice in the NHS long-term plan, if you'd like to know more. And just to say, there is some advice on levels of patients attending your hospital and at what level it might be appropriate to have a pathway team. So that you can see from this infographic that if you've got small numbers of homeless people attending each year, then obviously you've got this presentation, but there's some ideas about how you might, you know, provide extra information or make a link to a local authority. Between 30 and 200, you might need a named link hospital coordinator or a housing worker alongside some of the suggestions we've made here. But if you have more than 200 presentations a year, it really, really would be appropriate for you to have a full pathway team. So that's it for module 3. Just a reminder of these clinical networks training opportunities and resources. So the Faculty of Homeless and Inclusion Health, the Queen's Nursing Initiative, Homeless Health Network, and the London Network of Nurses and Midwives Homelessness Group all have free networks that anyone can join. They have all been started by clinicians, but you don't have to be a clinician to join. You know, receptionists, health support workers, frontline workers, anybody, please do get involved. It's free to join, as I say, and you'll get regular newsletters, opportunities to network with other people and access training. And the two links at the bottom, Fair Health and the London Homeless Health Programme, go through to other really, really useful free training and resources. So finally, just a reminder of that Michael Marmot quote, which is all about the fact that we need to remember that in order to redress that balance in health inequalities, we need to go more for people that have less. We need to really help people who have less to access health services effectively and well. So that's it from me. Just got 5 questions to go through at the end, and I'll give you 5 seconds just to reflect on them. So question 1 is, the Homelessness Reduction Act duty to refer applies to A, accident and emergency departments, B, surgical wards, C, outpatients departments, D, none of the above, E, all of the above. So the answer, as I'm sure you know by now from module 1, 2 and 3, is E, all of the above. This is just a reminder, if you are in any of those areas, this is something practical that you can do to make a difference to someone. Refer them to your local authority for help with housing. Question 2, the website link that you can use to find out about local support services is called, I'm not going to read all of those out, I'm going to give you a chance just to read those. So this is just to point out that it's B, www.homeless.org.uk. It's not Homeless Link, although the organisation is Homeless Link. Please do feel free to access the Pathway website, because that's got lots of resources on it as well. And Crisis is obviously also another website you want to go to. But the homeless.org.uk site will be the one that will give you up-to-date, relevant information on all homeless services in your area. Question 3, the website you can use to refer a rough sleeper to street outreach services is called, and the answer to this one is C, Street Link. All of the others are actual real names of services, but the website, which is a national website which will connect into your local outreach service, is called Street Link. Question 4, which of the following scenarios requires a referral to safeguarding? Known or suspected A, organisational abuse, B, self-neglect, C, discriminatory abuse, D, physical abuse, E, both C and D, and F, all of the above. The answer is, of course, F, all of the above, but it's just a reminder that previously it was C and D, and that there have been new things added in 2014 in the Care Act, and self-neglect is the most important of those. And then finally, question 5, in which of these scenarios should a mental capacity assessment always be undertaken? A, if a rough sleeping patient is self-discharging before returning to rough sleeping. B, if a rough sleeping patient refuses treatment. And C, if a patient who is well but has a background of mental health problems needs to be discharged to the street. D, both A and B, or E, all of the above. And the answer is all of the above. So it's just to reiterate that a mental capacity assessment is not just needed when someone is self-discharging and refusing treatment. If you know that a rough sleeper, there might be concerns about their mental health, there might be concerns about their cognition, there might be concerns about having multiple physical healthcare problems, you do need to understand whether this person is safe and understands how to maintain their safety on the street. So that ends module 3. We really hope that you have enjoyed all these modules and that you have got something from it. Please, please, please do get in contact if you want to know more. And that's it from us. Many thanks. Bye-bye.